Hello friends, welcome to Shrinetralay. This video I have presented at a conference Color at Dubai on 30th May. This conference is about keratopigmentation. Here I am showing few cases where I have managed the annoying light, that is unnecessary glare and halos, which patient is annoyed of. So in this first case we have a case of coloboma, and lens edge glare is a known fact which patient is annoyed of. Lens edge glare is something which make patient always uncomfortable to driving, and in evening hours he find it difficult. So to manage that, we have done a superficial anterior stromal keratopigmentation. An Indian ink is used to tattoo here. The keratopigmentation is a reliable procedure and does not cause any inflammation to the tissues. And I would like to underdo it first. So in case if it is required, it can be redone after 6 weeks. Additionally, this is one of the safest procedure and easiest procedure which can be performed by any good experienced ophthalmologist. Here I am using a keratopigmentation automatic gun to make a stromal puncture and using a water soluble ink to stain the stroma, so that unnecessary lights from the lens edge will not enter the eye and patient will not have any glare. There are people in Europe and USA who are performing keratopigmentation for cosmetic purpose also, but I usually perform it for therapeutic purposes only. So let's move to a second case where monoocular diplopia is a known complication in large PIs. One of my friend has done an ICL implant. Those were days when it was a generation 1 ICL without a central hole, and he has to perform a PI which was larger in size, and patient was complaining of monoocular diplopia. To manage this situation, I have a option of going intraocular and using the suture to close the PI, which was unnecessarily taking too much risk. So to manage this particular situation, superficial automated keratopigmentation is one of the easiest way to work out. So I did use an Indian ink again and intrastromal injection of this ink into stroma with the help of automatic tattoo gun is helpful in such scenarios. A BCL is applied in the end of the surgery for epithelial healing. So intense light glare is another issue faced in situations of ocular albinism. Due to large transillumination defects, patients with albinism find it very difficult to bear the amount of light entering eye. So after a good cataract surgery and a 3-piece IOL insertion in the bag, after 1 month of this procedure, I have performed an annular keratopigmentation, again superficial. Anterior stroma is stained with Indian ink, and that way we have prevented a lot of light entering the patient's eye. So this way patient could bear the amount of light entering the eye, and patient replied to me that he is able to drive his vehicle even in the sunlight, and that was very gratifying. Thirdly, in pseudophakic bullous keratopathies, I have used intrastromal contact lenses previously, and which has been proved to be safe for more than 3 years now. And using the same principle, what I have done is I have used a cosmetic contact lens intrastromally to treat the corneal opacities and gave the cosmesis to the patient. Though these things has to be more studied, more cases are required and a proper study and detailed evaluation with lot of cases is required. But this is one scenario which we can manage very well, and you can see the post-op case where I have used a cosmetic contact lens in the cornea and the patient was doing very good. I hope you enjoyed. Thank you and good day.